Hello, this is Dr. A. So if you're getting this, obviously you must be in quarantine or affected by COVID-19 in one way or another. So this is your lesson on chapter 1, and I will send you the link to this Nearpod in homework mode so you can also complete the activities here. Okay, so these are the few learning objectives for chapter 1. We're going to look at milestones in the medical system. We're going to look at primary, secondary, tertiary, and quaternary prevention, and we're going to look at the iron triangle and health literacy. Okay, so a few fun facts. So when the practice of medicine first began, tradesmen such as barbers practiced medicine. So get your hair cut and get whatever taken care of. And they often use the same razor to cut hair as to perform surgery. So yeah, like basically they weren't trained. In 2017, so that's the most recent data we have, the United States spent 17.9% of the GDP, gross domestic product, on healthcare spending, which is the highest in the world. We spend the most on healthcare. We're going to talk about that a little bit. So the U.S. is the only major country that does not have universal healthcare coverage. And by major country, they mean like one, yes, big, like compared to Canada and Australia and stuff, but also compared to basically what we would call first world country, first world, yeah, places where, you have a lot of technology, a fully developed economy and stuff. And the U.S., most of those places, you would think England, France, Germany, Spain, and then of course Canada, Australia, Italy, Switzerland, all of those places. Anyway, they have universal health care. So in 2002, the Joint Commission issued hospital standards requiring hospitals to inform their patients if their results were not consistent with typical care results. So that you had to notify people if their lab results were abnormal, if they got given the wrong medication and stuff like that. Couldn't cover it up. All right, sorry for that slight interruption. My phone was ringing and I really had to answer it because somebody I'd been playing phone tag with. So, so the summary. So the text, and this is, the chapter, but also just our textbook is going to give us information about that you need to know as a healthcare consumer, but also as an employee. So obviously, if you're in our college, nursing and health and stuff, you probably have ideas of working into the healthcare industry. So there you go. It does provide an overview of the history of the major sectors of healthcare, and we're going to look at traditional medicine and medical education. We're going to look at some of these milestones and stuff, nursing education, hospital system, etc. And but we're really we're going to hit up some of them. I'm not going to spend a lot of time because we're actually going to dive into that more specifically into other chapters. So the U.S. healthcare system, again, is one of the most expensive and complex healthcare systems in the world. We have so many moving parts, and it is really a complex system. It has both government and private sector participating. So, for example, think about it on the government side, like Medicare, Medicaid. So Medicaid being for the poor people, Medicare for the elderly people, that's government run. But then you have a lot of health insurances are private and stuff. You have hospitals that are privately owned, even if they're not for profit. And then you have government hospitals and stuff, think of the VA hospital system or the military hospital and military healthcare and stuff. So according to the latest statistics, which are 2017, so again, the U.S. spends 17.9% of its GDP on healthcare spending. So what does that mean? So the gross domestic product is the totality of everything that we produce as a nation. So anything that's been made in the USA and sold, even if it's sold overseas and stuff. Okay, so that's our GDP. And so 17.9% of that has been spent on healthcare. Now, why do we say this is a lot? If you go look at all the other countries that have even universal healthcare, you'll find that they at the most spend 10%. So it's usually somewhere around 9 to 10% of their GDP. Now the GDP obviously varies, and that's why you look at a percentage, because and that allows you to compare bigger nations with smaller nations and stuff like that. And so we spend a lot, and our outcomes are actually not as good as those that spend less on healthcare. Again, an idea of that is if you're still struggling with their GDP percentage of GDP's spending, an analogy would be, for example, if you looked at your annual income and looked at how much you spent, let's say, on housing, so with rent and utilities and stuff like that, and what percentage of your income is. So that would be an analogy of what we're looking at here with the percentage spent on healthcare out of the GDP, which would be the equivalent of your annual income. It's just like the annual, you know, if you will, income, or what's been produced by a country is what the GDP is. And so we have an expensive system, and unfortunately we're not at the top with life expectancy rates and infant mortality. Now, being in a video, I'm not going to play this because you will not get the sound, so please play this video. It's a really good explanation. And then do the activity here. So it's just an open-ended question. And so why do you think we spend so much on healthcare in the US? So why is that? Okay, so, and then we're going to move on to some basic concepts of health. So there are three main concepts of how healthcare is provided to consumers. So we have primary prevention. The goal of primary prevention is to avoid the development of disease. So examples would be smoking cessation, immunization, and educational programs for pregnancy and employee safety. So smoking cessation programs, for example, so it's basically the idea that somebody started smoking. We know that if they keep smoking, especially for decades, then one of the eventual things that's going to happen could be cancer, it could be high blood pressure, you could have COPD, respiratory issues, and all that. So like it's going to mess up your health long term. And so if we can catch it early and get somebody to quit before they start having issues, then we're into primary prevention. And of course, getting immunizations and stuff, the idea is to expose you to an inactivated form of the virus so that you can build immunity, and if you're exposed to the virus again, you don't get sick. And you know, educational programs, education is key. Pregnancy, but also employee safety. So you know, care, pregnancy care, prenatal care, all that kind of stuff, prenatal visits, all the things to do and as a worker, like safety protocols to prevent you from getting hurt. So all that falls under primary prevention. Okay, so secondary prevention activities are focused on early disease detection, which then prevents the disease from getting worse. So screening programs that check for high blood pressure or high cholesterol, meaning like maybe you can catch it, because you can have high blood pressure for a while and not really have any signs and symptoms, or like really not be cued into them. And if you don't take care of that high blood pressure early on, then it can mess up your kidneys. You can go into chronic renal failure, you can have stroke, heart attack, all kinds of problems and stuff like that. So in a way, we're not by detecting it early, we're not preventing the person from getting high blood pressure, but we're preventing from getting the consequences of high blood pressure, right? And same thing with colonoscopies or in mammograms. A colonoscopy and a mammogram does not actually really keep you from getting breast cancer or colon cancer. It just allows the physicians to detect it sooner. And so these are screening tests that can be done. So that if we detect it early, then it's a lot easier to treat, and you can prevent it not being detected until it's in late stages and it's not treatable. And in tertiary prevention reduces the impact of an already established disease by minimizing the disease-related complications. So usually focuses on rehab and monitoring disease individuals. The best one I can really give you there is, for example, diabetes, and managing the blood sugar of the patient. So making sure that they are checking their blood sugars, that they're sticking with their diet and their lifestyle changes by checking their A1C is one of the tests that they can do to check on that, to also screen them for renal issues early on, because you know, the diabetes can affect the kidneys, and screening their eyes and stuff like that, so that you can, you're not, you know, by doing these prevention techniques, you're not going to keep them from having diabetes. It's just that you hopefully could keep them from going blind, from, you know, their kidneys shutting down and stuff like that. And then coronary prevention is a new concept, so it's an extension of tertiary. And it's basically state-of-the-art medical care, but it's the mindset of mitigating unnecessary efforts on care that may not be working. So it's the less is more. So let's say in an example of a cancer, they're like, okay, well, we can do this chemotherapy, but then you know, they do X amount of rounds of that chemo and all that, and it's not working. Well, that means then, okay, let's stop that and maybe explore a few other things, but maybe they'll explore, you know, care that is not chemo. So maybe some immunotherapy and stuff like that. And so, again, not just throwing everything at it, but really using things that can specifically work, but not overdoing it and stuff like that. So it's kind of a newer one there because the way care has advanced. So for this little activity, I want you to give me an example of either primary, secondary, or tertiary prevention of a disease. So just put whichever one you pick. You can put primary, secondary, or tertiary, and then give me an example. So you can just say, oh, I'm going to do secondary, put secondary, and then do an example. Okay, so let's talk a few milestones. I've kind of just crunched these up a little bit. So medicine and medical education, so where we came from, where we're going. 1700s and 1800s, physicians were trained on the job. So basically, if you wanted to get a doctor, you just had to find somebody that was practicing as a doctor, but there was no like formal education, there was no licensure, there was no nothing. If you basically could kind of decide you wanted to be a doctor and kind of learn the trade the way you would learn to be a carpenter or learn to be a plumber or something like that, right? And you were basically trained on the job. There were only about 4 medical schools in the entire United States, and there was no mandatory testing, so the standards were really low. And so in the 1900s, the AMA, the American Medical Association, was founded, and it was founded to protect financial interests of physicians and also to standardize medical education, not medication. Medical education. And the AMA to this day is still very active to protect physicians' interests. In the early 1900s, then most physicians were family physicians, and they were in solo practice. So they practiced maybe out of their house in a little local clinic or something like that. That was theirs. And you paid cash price for services. So these might be some of the old movies where you can see where the farmers want to trade, you know, a cow or a chicken or something for, you know, barter system for medical services, but you were expected to pay for the services. A little bit like how it is for dental care now, even if you don't have dental care insurance, like you're expected to pay when you get the care. And then the Flexner report led to the MCAT test for admission into med school. So the Flexner report actually looked at the state of medical education, which was really substandard, and so decided to raise the standards by creating the MCAT admission test. And therefore like raising the standard of medical education. Then in the 1940s and 60s, group insurance changed the dynamic because now it wasn't just the patient paying the provider. There was a third party added in there with insurance, and so there was like a go-between, and maybe part came from the patient, part came from the insurance of the payment. And then in the 1970s and 80s, there was no restriction on reimbursement. So basically, with the way the insurance was, is whatever you had done or the doctor decided they wanted to run test-wise or whatever, they would just file for that and that would get reimbursed. And so that became kind of a source of income for the doctor. So there was incentive basically to run a bunch of tests because you got reimbursed, so you had more money coming in and stuff. And physicians would own their own labs and stuff like that because they could make money from it. And so, but that drove the cost of healthcare up to the point that managed care was created in the 1990s to restrict reimbursement and try to control this inflating healthcare costs. So to give you an analogy, would be kind of like your dad or mom or parent giving you a credit card and say just buy whatever you want and we'll just pay for it and stuff. And so you're like no restriction, you can just just, if you want it, just get it. And so basically there was no incentive to not run a bunch of tests or to not run expensive tests because it was being reimbursed, but it greatly inflated the cost of healthcare. A little bit on nursing education. So in the late 1800s, nursing programs were created and nurses started to organize in professional associations requiring licensure to practice nursing, the trade of nursing. In the early 1900s, nursing care was needed for World War I and to staff these newly created hospitals that were being built. So there was a need for nurses, and that need for nurses pretty much stayed from the time they've been created. In the mid 1900s, so the nurses were needed for World War II, so that was in the 1940s, right? And then nursing schools, they decided to move it from the hospital setting. So you initially, before that, if the nursing schools were within the hospitals and you were trained at the hospitals and stuff, and they moved it to academic settings, so like universities and stuff like that. Although you can still find across the country some nursing programs that are hospital based, but they're very few and far between. Most of them have gone to academic settings. In the 1970s, nurses can diagnose and prescribe. So that was a new one. So that's kind of like, it was a little bit of a battle because it's kind of infringing on the doctor's territory and stuff. But there was such a need that this happened. And this is where you get nurse practitioners and stuff. And the early 2000s, not 200s, I just saw that, sorry. Omitted a zero. Studies showed that patient outcomes improved if nurses had a BSN, and so incentives followed. Hospitals were reimbursing or providing scholarships and stuff for nurses to go back to school and get their BSN. So the milestones of the hospital and healthcare system, a few of them. So in the 1800s, all there existed was almshouses, pest houses in early hospitals, but the conditions were really bad. So you basically didn't go there unless you really had no choice, or the pest houses were like for quarantine and stuff like that. Almshouses were for poor people that like were homeless and, you know, having but it was much better for you to get care at home, to get a physician to come to your house. The conditions were much better. Women gave birth at home and stuff like that because the outcomes if you gave birth at hospitals were really, really bad. And then in the early 1900s, medical technology started to advance the quality of care. Like you can look at the advent of x-rays, the beginning of testing, lab tests started to be developing and stuff like that. And and if, you know, innovation, new equipment, all that kind of stuff happened. And hospital ownership shifted from physician-owned to church groups and states or regions owning hospitals. 1970s and 80s, the Patient Bill of Rights. So you had to be informed of your rights when you went to hospitals and stuff like that. And then for example, you have the right to refuse a procedure and that kind of stuff. You have the right to know how much some of the stuff is going to cost if you ask. In the 1980s to 90s, EMTALA, in that decade, EMTALA was put in. So that is the act that says that hospitals can't turn patients down, so that like if you come in gravely injured, they have to at the very least stabilize you, even if they need to ship you to another hospital and stuff like that. So you cannot turn anybody away, even if you have no way to pay for it. Okay, so that's EMTALA. In 1996, the hospitalist position was created. So those are physicians that are tied to the hospital and they only work in the hospital. They visit patients in the hospital, and they coordinate care for those patients and stuff so that the family physicians can stay in their family practices, and then they coordinate with the family physicians and stuff. And in the early 2000s, the quality surveys started to be administered to improve the quality of hospital care and stuff like that. And so hospitals are ranked based on these quality surveys. And they've even gotten to where they tie reimbursement back on some of these quality measures and stuff like that. And in 2010, of course, ACA, Affordable Care Act, or Obamacare, was put in place to increase access to care and health coverage, health insurance coverage and stuff. Okay, so a little bit on government participation in the system. So there's other milestones in your book. You can go back and look. So several federal agencies are responsible for enforcing rules and regulations. So the FDA is a big one, the Food and Drug Administration. So food and drug, we're obviously more interested in the drug part in the healthcare system. So they approve obviously drugs that are prescribed, and they also decide if it can go to be over the counter versus prescribed and stuff like that. So they are the gatekeepers to what goes on the market and stuff like that, and they can also pull stuff from the market. But it's not just drugs, it's also devices. Anything that can be implanted or put into a body has to be cleared for the FDA. Also supplements and stuff like that. They have their hands on that, and of course food and quality of food, that would be the other end of it. And then the Centers for Medicaid and Medicare Services. So Medicaid is basically government health insurance for the poor. You have to meet certain criteria to qualify. And then Medicare is government health insurance for the elderly. So you have to be a certain age and be retired to qualify for Medicare. The Agency on Healthcare Research and Quality, they're behind some of those quality surveys and stuff, but they look at basically quality of healthcare services by doing research and stuff, and they can help determine best procedures and stuff, especially for the money. The Center for Mental Health Services, of course, that's self-explanatory, right? To help coordinate mental health services and all that, but also starting to get reimbursement for mental health services. So that's part of government participation. And then the CDC, we've heard a lot about the CDC, obviously in the last 6 months to a year. So the Centers for Disease Control and Prevention, and they coordinate with the World Health Organization and stuff and help prevent or mitigate the spread of epidemics and pandemics and stuff like that. And there are a certain number of diseases that are reportable to the CDC from hospitals and clinics and stuff. And then the CDC tracks these outbreaks or the disease, the rate of these outbreaks of disease and stuff like that in locations. So it's a very valuable organization. Okay, so I'll give you some scenarios. So on this one, it's a poll. Which government agency would be responsible for approving a new hip implant for hip replacement surgery? And I'll be giving you these answers later, like probably through an email. So which one do you think it is? The FDA, CMS, Medicare, Medicaid, AHRQ, the quality one, or CMHS, which is mental health. So select your answer, and then next question is which government agency would evaluate the hip replacement procedure to see if it's the best quality for the cost. And then your third question is which government agency might be involved in setting the reimbursement price for the new hip replacement procedure. So there you go. A little bit on social legislation as part of the government involvement. So social regulations are rules and regulations that protect consumers, so protect us as users of the healthcare system. So the Sherman Antitrust Act is a big one. So this one basically prevents monopolies. So it prevents, for example, there just being like one big health insurance reimbursement, or there only being like one network of hospitals and stuff like that. So preventing monopolies, especially here within healthcare, but also elsewhere. Because if you have the monopoly on something, you're the sole provider of that service, you can pretty much set whatever price you want because there's no other options. So that's the idea behind the Sherman Antitrust Act. The Newborns and Mothers Health Protection Act was passed to basically keep hospitals from kicking moms and their newborns out too early. So to make sure that they got appropriate care. And so I know you have to at least stay 24 hours and stuff like that, so they can't kick you out before that. But then there's like, if you've had a C-section, it's longer. And so anyway, so that's that. The Women's Health and Cancer Rights Act prevents discrimination on for women if she has cancer. The Mental Health Parity Act increased access to mental health care by providing reimbursement for basic mental health services and stuff. The Genetic Information Non-Discrimination Act prevented insurance companies from discriminating against you you've had your DNA analyzed. So let's say you had your DNA analyzed and you show that you have, if you're a woman, you should have the BRCA, which is the breast cancer gene. And that is reported, let's say your health insurance sees that, or somehow they get reported that, then all of a sudden your health insurance bill or whatever goes up, like your cost for health insurance goes. So that would be a discrimination based on your genetic information. You don't even have breast cancer, but just because you have the gene, they could charge you more. So this prevents that. It prevents you from being discriminated against because of something in your genetic code that might lead you to potentially develop a certain disease later on. And the Lilly Ledbetter Fair Pay Act was enacted. It was a little bit about women pay, but it really is about just non-discrimination in pay. So that, like, if you are an RN, you should be paid X amount, and it shouldn't be, oh, you would pay this much if you're a woman, but this much if you're a man, or you can be paid this much if you're white and this much if you're black. And usually they would pay whites more than black and pay men more than women. So this kind of just leveled everything. Just like you have to, disclose how much you pay, and it has to be fair, and another person, regardless of who they are, with the same training, should be making the same amount of money as you. And then, of course, the Affordable Care Act, which we'll be getting into that, which increases access to healthcare and healthcare coverage. All right, so look up one of these social legislations that was listed, and again, you can give a brief description. If you click on this picture here, it gives them to you. So just look one up and give me a little bit more about that. Private participation. So we've talked about the government part, influence. Let's talk about the private part. So healthcare costs are paid by private or public health insurance and the enrollee of the plan. So private or public, depending on which system you're in. So let's say you have a Blue Cross Blue Shield, and they cover X amount. Let's say they cover 80%, and then you have to meet a deductible and stuff like that. So part of it, those healthcare costs are paid by the insurance, and part of it are paid by you. The ones that are paid by you are out-of-pocket cost. And so that could be in simply one, paying for the health insurance. Usually the employer pays for some, you pay for some. So that could be paying for the actual health insurance out of your paycheck. It could be paying a copay when you go to a visit. Maybe you have to pay $30 or $35 or $50 or something like that just to go see the physician. Or it could be like if you've had hospitalization and stuff, you have to meet a deductible. So you have to pay the first $600, $1,000, whatever. And then after that, they pay X amount. So those are all out-of-pocket costs. In 2017, private health insurance, for example, Blue Cross Blue Shield, covers 67% of individuals in the country, and 56% of those 67% were covered through their employer's healthcare benefits. So your employer is really your biggest source of healthcare benefits. Of course, that also for small businesses, that can be problematic. So they've also, after the ACA, were able to link up and purchase, purchase more like a big hospital or big companies could purchase. But that is one of the perks of working for big companies and stuff, is they usually have quite affordable health insurance and stuff like that, because they're bulk purchasing. And the concept of iron triangle. So the iron triangle is a balancing act of access, cost containment, and quality. So it represents three factors within the healthcare system that are important. So the quality of the service, the cost of the service, and the accessibility of the service have to be in balance in order to provide good healthcare. So let's think about how imbalances could potentially occur. Of access, as you being able to get to or buy or purchase the service. Quality, what is the quality of what you're buying, right? So like if you think just in purchasing clothing, for example, so access would be the stores that are available. So for example, in this area, our access has been slightly limited by the destruction of the mall, right? Some of the stores, if you have noticed, have purchase spaces outside of the mall into strip malls and stuff so they can keep giving access to their store, to their merchandise for their customers. Okay, quality and then cost. So higher quality stuff usually costs more, right? But it's usually it's linked, but not always. So if cost goes down, usually quality goes down too. If cost goes up, quality goes up. But then if cost goes up and quality goes up, access goes down because it's harder to pay for it. So, so those are the moving parts of the iron triangle. So if the 3 points of the triangle are not balanced, then problems can arise. If you get an increase in costs, you will decrease access, and a decrease in, if you decrease the cost, quality can suffer. Okay, so in this activity here, I want you to give me an example of an imbalance of the iron triangle and stuff like that. So you can make it very specific if you want to just some facet of healthcare. So lastly, in conclusion, so the U.S. does not have universal healthcare coverage as other first world countries have. Health disparities do exist across the nation. So this is a quote that actually, well, I like because it's true, is your health is determined by your zip code more than anything else, more than your habits, more than your genetics and everything like that. So where you live. So the U.S. has the most expensive healthcare system in the world. In 2017, 29 million people did not have healthcare insurance coverage at some point during the year, and this is after ACA was passed, right? Which was a decrease from the 50 million in 2010 when ACA was passed. The healthcare costs are covered by governments or by private health insurance or by individuals. It's usually a blend of all of it. So there you go. Now, if you have any specific questions that you want to ask, you may put it in here and I will look at them and send you the answers. So that is your lesson and your activity for Chapter 1. I pray you guys stay healthy and well and that we get to see you soon.